Thank you for inviting me to speak at the Chinese HIV Clinical Forum Educational Series 2021. I will develop the topic of long-term management of metabolic changes. These are my disclosures. For people living with HIV with access to antiretroviral therapy, HIV infection is no longer deadly, and CD4 cell counts can be preserved or increased if they were low, and age, conditions, and particularly death may be prevented to levels similar to those in the general population. However, the cost of surviving HIV infection has put forward new problems. As people age, we can develop comorbidities, and the number of comorbidities may increase with aging. But people living with HIV for a certain age has a higher number of comorbidities than the general population. And this is why the prevention and the management of these comorbidities, including metabolic problems in people living with HIV, makes sense. So in general, and in a summarized way, I would say that the risk factors for metabolic abnormalities in people living with HIV are three: the person, the infection, and also the therapy. For a person, and I will start with weight, we have to consider that in adults, we think of ourselves as having a stable weight over time, but the natural history of aging shows that there is an increase in weight for both for men and women over time. So the natural history regarding weight is an increasing expectation. Certainly for those people who are already overweight or obese, this may be a much higher problem, and the strategies that can be set should be to prevent this weight gain be higher than expected. You can see here on the left-hand side that the genetic background and also the environment, the lifestyle, may impact on weight, and weight can be pathogenetically explained by insulin resistance. So a weight gain beyond average, beyond normality, may lead to insulin resistance. And insulin resistance may have clinical consequences in namely diabetes, dyslipidemia, high blood pressure, coagulation problems, and also cardiovascular disease. And all these conditions may be interacting among them to increase the risk of atherosclerosis. In HIV-infected people, the current status about weight is that it is in general lower than in the general population. HIV-infected people, particularly at the time of infection and later on, may have a lower weight in general than that of the general population. However, as you can see on the right-hand side in green, the speed of increase in weight is much higher than that in the general population. And certainly, if a situation is like this, we can expect to have a similar and even much higher weight in the HIV population than in the general population in the near future. For people living with Lipo Dystrophy, and this is a condition of the past, fortunately, but those patients who were HIV positive maybe 20 years ago and had therapies that might contribute to lipo atrophy, the potential for gaining weight is only at the expense of abdominal fat, intra-abdominal fat. And this is not only an aesthetic problem, but it has also metabolic consequences. In fact, we studied a cohort of HIV-infected people who started therapy with with 2 nucleosides and a protease inhibitor, which was the standard therapy 20 years ago, and we have followed these people over time, at least for 16 years, and we have seen that the risk of developing hypertension, diabetes, or cardiovascular events is higher than expected. It's significantly higher. HIV itself may promote cardiovascular disease through TAT on the left-hand side. HIV may infect the arterial wall and may produce inflammatory cytokines that may contribute to cardiovascular damage. And also on the right-hand side, HIV through the NEF component may also prevent the scavenger effect of the cholesterol in the plaques, but by HDL, thus promoting the formation of atherosclerotic plaques. In fact, when HIV had no therapy in the past or therapy was suboptimal, HIV-infected people progressed to AIDS, you can see that HIV infection was associated with lipid changes. And these changes were an increase in triglycerides and a decrease in cholesterol fractions, as you can see in red. But regarding cholesterol fractions, you can see that the decrease in HDL cholesterol was much higher in proportion, 50% decrease, than that in total cholesterol or LDL cholesterol. So certainly the effect of HIV infection by a net decrease in HDL cholesterol was a pro-atherosclerotic effect. We know that some antiretrovirals may increase lipids, and particularly protease inhibitors, lopinavir more than darunavir or atazanavir, and particularly the boosting agents that most protease inhibitors need. Ritonavir has a much higher hyperlipidemic effect than cobicistat. Also, some drugs may promote weight gain, and namely integrase inhibitors, and particularly second-generation integrase inhibitors, pictegravir and dolutegravir, may have the highest risk for developing weight increase. And regarding nucleosides and nucleotides, TAF has a higher risk than any other nucleoside, as you can see in this study, and particularly much higher than that of TDF. It was a matter of controversy whether the effect of TAF promoting weight gain was because of itself or because of the loss of the protective effect of TDF that was interrupted and switched to TAF. And some studies, and this is one of them, have clearly shown that switching from drugs other than TDF to TAF, as you can see at the bottom of the slide, from abacavir to TAF, may also lead to an increase in weight in those patients treated with TAF. So certainly TAF has a weight-promoting effect. I would like to address your attention to the EACS guidelines, the European AIDS Clinical Society guidelines that are freely available on internet, and you can find suggestions to prevent and manage comorbidities in people living with HIV, and particularly with metabolic comorbidities. And I'm very aware that this course is addressed to Chinese-speaking areas, but even you are working outside Europe, please, you can not only consult the guidelines, the European AIDS Clinical Society guidelines, but also to become members of the European AIDS Clinical Society guidelines. Well, first of all, we need to treat HIV infection because HIV is the cause of everything bad. So we need to treat HIV infection. And you can see in this study, the START study, and in others the same way, on the right-hand side of the slide, that the development of serious non-age-related events was much lower with an immediate initiation of antiretroviral therapy than with deferred initiation. So certainly the treatment of HIV infection may lead to better HIV-related effects, but also to non-HIV directly related effects such as comorbidities. When using antiretroviral therapy, you can have a variety of drugs to choose among them. And I would say that one of the characteristics to choose antiretroviral drugs would be the toxicity profile not to be coincidental with the comorbidities that the patient may have. So for instance, with TDF, you may have a higher risk of kidney or bone toxicities, and certainly in patients with osteoporosis or chronic kidney insufficiency, you should not be using TDF. And this is very, very useful. And the same for the anchor drugs. For instance, regarding metabolic issues, you can see that efavirenz and also protease inhibitors may be associated with dyslipidemia, and integrase inhibitors may be associated with weight gain. A common controversy has been whether in people with dyslipidemia, in HIV-infected people with dyslipidemia, what's better, to treat as in the general population with statins, or to treat with changing therapy, which is more specific to HIV-infected patients. And we performed a study in people treated with boosted PIs with dyslipidemia by randomizing them to either switching the PI to a lipid-friendly drug or adding a statin, in this case rosuvastatin. And we were able to clearly see that the statin had a much higher lipid-lowering effect than the switching of the protease inhibitor, although sometimes both strategies are needed in the same patient. Statins work similarly well in the HIV-infected patient as in the general population, so no problem with this. And just a reminder that the statins have not the same efficacy, maybe differences among them. And I would say that those on the left-hand side of the slide, rosuvastatin, atorvastatin, simvastatin, pitavastatin, are the ones with the highest efficacy and should be preferentially used. Statins are not the only lipid-lowering therapies. There are others, ezetimibe, and also more recently, the PCSK9 inhibitors, particularly evolucumab, that has been tested in people living with HIV, and it has shown similar safety and efficacy as in the general population. I want to address your attention that the antiretroviral therapy and the statins may interact, and the boosting agents, particularly ritonavir, may increase the statin levels and the non-nucleosides, because of the increase in metabolic pathways, may decrease the statin concentrations. And this has to be considered to avoid toxicity and to get a good efficacy. Statins may have also, beyond the lipid-lowering effect, anti-inflammatory properties shown in this double-blind randomized clinical trial, and that's a potential for a condition of dyslipidemia within the frame of HIV infection, which is an inflammatory disease in itself. For this reason, the REBRIEF study, which is the largest randomized clinical trial performed in people living with HIV, more than 6,500 people followed for more than 6 years, and people living with HIV with no specifically higher cardiovascular risk, they will be followed. The primary endpoint will be cardiovascular events, but also other comorbidities and ultimately death will be endpoints. And you can see this study is running, is beyond the equator, and if the results will be important, and if the statin therapy proves to be positive in this way, it will change the way of treating HIV-infected patients in the future. Also, to treat and to prevent obesity, I would say that for those people who are obese or overweight with some associated conditions, we should aim interventions. We should consider an objective of at least 5% weight loss, and the management should be comprehensive, including a reduction in the intake and also an increase in the physical activity, and all this supported with behavioral changes in the mid-long term of at least 6 or 12 months. And you can see further details at the European AIDS Clinical Society guidelines. So in conclusion, despite virological control, people living with HIV are still at risk of metabolic problems. They have a higher risk of dyslipidemia and weight gain, and the risk is much higher with aging and with prior Lipo Dystrophy. HIV infection itself may cause metabolic problems, so treat with antiretroviral therapy as early as possible. Regarding weight, second-generation integrase inhibitors and TAF may have the highest risk. Consider statins whenever decreasing cholesterol. Think of weight interventions as a comprehensive intervention, and you can look for further details at the guidelines. And beyond your local or national guidelines, consider using the EACS comorbidities guidelines. Thank you for your attention.